Thank you very much. Over to you, Dr. Josephine.
Thank you very much. Paul, can you hear me?
Yes, yes, go ahead, I can hear you.
Yes, first of all, I would like to apologize for the late start. I've joined in late because of internet issues. I don't know what happened to my phone, but it doesn't connect with my computer. So I don't know this is happening for the first time. So I'll start by introducing myself. Dr. Josephine Namugenyi. I'm a surgeon and a urologist. So today our topic is prostate cancer, bridging awareness and advanced care for the better outcome of our patients. I'm going to be a bit fast because I think my slides are quite many compared to the time. I've been given how many minutes?
40 minutes.
40 minutes. Okay. I think we can be able to cover all. So what we know about prostate cancer, I wanted to start with what a prostate is, because I'm aware that what we have here is not only the surgeons, but also we have lay people. So I'm trying to share my slides. Are you able to see them?
Yes, yes, we can see them.
Are they moving?
Yes, they are.
Okay.
Please go
So
ahead.
a prostate is a walnut-sized organ that is located below the bladder. It's behind the base of the penis and in front of the rectum per se. It surrounds, part of it surrounds the urethra, which is a tube-like channel that carries urine and semen through the penis. Its primary function is usually to produce seminal fluid, which usually supports, protects, and helps in transportation of sperm. The prostate as a gland has different parts, or what we call zones. So they are mainly four. We have the peripheral zone, which makes the biggest part of the prostate, makes 70%. We have the central zone, which usually surrounds the seminal vesicle duct. We have the transition zone, which surrounds the urethra. Like we said, it surrounds part of it surrounds the urethra. It's mainly the transitional zone that surrounds it. And then we have the anterior fibromuscular stroma. The transition zone is the one which is usually affected by BPH, the benign prostatic hyperplasia or benign prostatic enlargement. And for MEDIX, it also has different cells. It has glandular cells, it has smooth muscular cells, and it has stromal cells, and also epithelial cells. So we shall see the purpose of those cells as we go on. So because of our topic today is prostate cancer, and I thought it important to indicate where exactly the cancer affects. So the biggest majority of the prostate cancer affects the peripheral zone, but that doesn't mean the other zones are not affected. So 15 to 20% affects the central zone. Then in 10 to 15%, you can find it in the transition zone, the zone which is said is usually common for BPH. The fibromuscular zone is rarely affected by prostate cancer, although it can be found there. So what are the diseases for the prostate? The prostate can be affected by both benign and malignant conditions. The benign conditions, like I've mentioned before, it is the prostatic enlargement or hyperplasia. We have infectious conditions, which may include prostatitis, which may be acute or chronic. You may have genitourinary TB. Sometimes you find cysts, sometimes also stones. Genitourinary stones in the prostate can be found there. But also it is affected by malignant conditions. The major condition which we are going to look at today is the prostate cancer, but also it can be affected by cancers which are coming from elsewhere, from the surrounding structures like CA bladder can affect the prostate. CA rectum can erode into the prostate because those are structures that are next to it. So it can also be affected by the metastatic disease from other areas. So critically, because we are looking at prostate cancer, we are going to define it. It is defined as a malignant tumor that is found in the prostate gland. There are different types of prostate cancers, but the commonest in more than 95% of cases is the adenocarcinoma. But there are also non-adenocarcinoma cancers, which make up less than 5%. And they include the transition carcinomas, small cell carcinomas. So usually when you get your histology, they will indicate to you the type of carcinoma that they've seen, that the pathologists have been able to see. So in our epidemiology, prostate cancer is the most common cancer among men in our African setting. And it's the most, the most common overall. In sub-Saharan Africa, it has a higher burden, partly because our patients, of course, come late. It represents about 20.3% of all cases in men, with Zimbabwe and Uganda, our country, having the highest instances of prostate cancer. I don't know whether because the studies have been done more, or indeed we actually have the highest instances. In Uganda, the incidence of prostate cancer is between 37 to 68 per 100,000 cases. That's quite high. Although it's a bit, it's below the Black American men, which is estimated at 172.8 per 100 men. But don't forget that our studies are not as long as the Americans have been doing theirs. So they may have a higher incidence simply because they've been doing these studies for a longer time than us. Mortality from prostate cancer is quite high, especially in our African setting, because our patients, again, they come late. So what are the risk factors? Old age is a factor. So the older one gets, the higher the chances of having prostate cancer. In fact, the studies that were done as far as prostate cancer was concerned, they found that when a man is almost all men in their 80s, 90s, and 100 years, they are all, when you get their prostates and you do histology on them, you might find that they all have prostate cancer. But the older they get, sometimes they die from other issues, but the cancer may not affect them. Another predisposing risk factor is race and ethnicity. Black men have a greater risk of prostate cancer as compared to other races. The Caucasians have the lowest. And also prostate cancer in Black men is more aggressive and advances faster. Having a family history of prostate cancer or breast cancer predisposes one to have a high risk of getting prostate cancer. So familial predisposition occurs in men who have either a father, a brother, who has been previously diagnosed with prostate cancer. So it is usually encouraged that if you see such men, you encourage them to also get screened. If they have any relative who has died of prostate cancer or who has been diagnosed with prostate cancer, it's encouraged that they also get screened. The other thing is having family history, family genes. The BRCA1 and the BRCA2 genes also predisposes one to prostate cancer. Obesity was also found to have a high risk of prostate cancer, and also diet. People who have an intake of lower blood levels of vitamin D, they have an increased risk of developing prostate cancer. But also intake of red meat and other dairy products also predisposes one to have a high risk of having prostate cancer. Hormones were also found. Elevated blood levels of testosterone may also increase the risk of having prostate cancer, because testosterone works well it tends to encourage the growth of the prostate cancer cells. So there are amongst the risk factors, there are also myths and non-risks, which in Africa, especially in our African setting, were believed to be causes of or risks of having prostate cancer. For example, sexual activity, high levels of sexual activity or frequent ejaculation were rumored to increase the risk of prostate cancer, but this is not true. Vasectomy, having a vasectomy of getting prostate cancer, but this again was proven to be wrong. Certain medications were believed or to have a link between having lower instances of prostate cancer. This may result that one of such drugs is aspirin. It is believed that intake of aspirin may reduce the risk of having prostate cancer, but studies are still ongoing. This has not been proven, but those who are pro believe that through reducing inflammation, that is how the aspirin is able to reduce the risk of prostate cancer. So what is the natural history of prostate cancer? How does this disease start, and how does it move on? So initially, the cancer cells will develop as, they will just be like a clump of cells confined to the prostate gland. Sometimes we may, when you have a screening biopsy in such men, they may report to you like someone has carcinoma in situ or PIN, which we call prostatic intraepithelial neoplasia. So this may mean that the cells that may change into cancerous cells may be present. For the PIN, usually they may give you low-grade PIN or high-grade PIN. In case you see high-grade PIN, the risk of having prostate cancer is high. Those cells may predispose later, may change into prostatic cells. The ones, in case you get a report which shows low-grade PIN, that means the cells are less likely to develop into prostate cancer. So over time, these cells can multiply and they spread surrounding the prostate tissue and then forming a real tumor. Eventually, the tumor may grow into large enough and may invade go beyond the capsule and invade into the structures that are surrounding it. And this is usually what we call locally advanced prostate cancer. But if the tumor spreads further, it may go beyond the pelvic, it may through the bloodstream or through the lymphatic system. Then if at all the cancer cells affect other organs which are away from the pelvic area, that means that's what we call metastatic prostate cancer. So like I said, there are different routes of spread. It may spread by direct extension, like we saw the anatomical location of the prostate. It may spread directly into the rectum. It may go directly into the seminal vesicles, which is the commonest. That's where they usually go commonest. Sometimes the prostate cancer may go into the bladder, okay, but also into the lymph nodes that are around it, okay. So that is local spread. But when they go beyond, they may go through blood, that is through the bloodstream or through the lymphatic system to reach other distant areas, causing metastatic prostate cancer. How does a patient with prostate cancer present? So in the early stages, the patients with prostate cancer may actually be asymptomatic. And this is why we encourage screening, because you can catch it early before it starts to bring any issues. However, for locally advanced prostate cancer, patients may present with lower urinary tract symptoms, just like the patients of BPH. So they may present with difficulty or frequency in urination. They may present with a history of urinary retention, or at that time they come to you with urinary retention. They may present with reduced urinary stream or hematospermia, that is blood in urine, or they may report to you painful ejaculation or painful urination. Or sometimes they may present with frequency or nocturia. Frequency, that is daytime, they go several times to urinate, or they may be waking up very often to urinate. Okay, sometimes they may present with urgency or with dribbling. And when you see such patients, that means the tumor is now affecting the urethra. That's why you're getting those irritative symptoms. I try to include a diagram there for one to understand. So those are patients who have locally advanced. But metastatic prostate cancer, sometimes we get our patients, and actually for patients who in our area, we commonly get patients who have metastatic disease, and those ones usually may present with back pain, persistent back pain, or the back pain may be so bad that it is not relieved by any painkillers. The mets may be as a result, the mets to the back pain may be as a result of mets to the backbone, okay? But also the mets to the bones may cause pathological fractures. So a patient comes to you with actually a fracture. It may be the lower back, it may be the even fractures of the lower limbs, but commonly it is the back. Sometimes they present to us with spinal compression, and as a result, they may present with paralysis. They are unable to walk. Okay. So other ways of them presenting, they may present with the general symptoms like anemia, weight loss, weakness, nausea, and renal failure. But all these are late symptoms. If such a patient comes, that means they're already having metastatic disease. So how do we assess and diagnose prostate cancer? Of course, we start with a history collection. We get to know how our patient has been. We get their presenting complaints. We get to know about their, as a medic, you have to ask about their family history. You want to find about their deity. So all those will tell you, give you an idea of what the patient is presenting with. And of course, we do physical examination. When you examine the patient, they may, if they've come late, they may present with the general symptoms that we've mentioned above. But commonly they may present with lower urinary tract symptoms. So when you see such patients, and of course the age group, the age group also says a lot. What I forgot to mention is the older the patient, the less likely they are likely to die of prostate cancer. The prostate cancer in young men, especially of African setting, is very aggressive. So it can kill them earlier. But those ones who get it maybe when they are in their 80s or 90s may not die from prostate cancer. They can actually die from other things, other illnesses. So the two primary diagnostic tools that we use in diagnosing prostate cancer is the digital rectal exam, whereby the prostate can be, the medical personnel can place their finger into the rectum and they feel for the prostate. You feel for the its consistency. If there are any nodules, you can feel for them. And also you feel if there are any invasion into the rectal wall. The other thing is the prostate surface antigen. This is a fluid that is being produced by the prostate itself. So it's an enzyme produced by the prostate itself, which I'll say much more about it. So the digital rectal exam, like I said, this is on this slide, there is a pictorial diagram to show exactly what happens. If you remember when we were starting our lecture, the anatomical position of the prostate makes it easier to be located through the rectum. So for medical personnel, a medical personnel can use a gloved finger and palpate on the prostate. And this is very important for clinical identification of patients. So the major things we use is mainly the digital rectal exam, and also which gives you a high degree of suspicion, and also the PSA, prostate surface antigen. So the use of both PSA and digital rectal exam increases your positive predictive value of finding prostate cancer. So more about the prostate specific antigen. Like I said, it's a protein, it's a glycoprotein or an enzyme which is secreted by the prostate epithelial cells. It is mainly found in semen, with some small amounts being released into the bloodstream. It helps to predict the risk of prostate cancer. However, you have to remember that a single elevation of PSA may not prompt a prostatic biopsy. Usually when we see that when you have a digital rectal exam, which is suspicious, plus your unelevated PSA, this may guide you for you to send a patient for prostatic biopsy. Of course, the prostatic biopsy will be the confirmatory test. But how do we use the PSA? So if a single elevation of PSA has been found and the patient has not had any complaints, you may want to defer and you repeat that PSA after a few weeks, okay? If a patient has issues like genitourinary infection, if they've had any prostatic trauma, maybe through cycling, maybe through instrumentation or recent catheterization, and you find that they have an elevated PSA, you may want to defer and do it a few weeks later. So other terms that we consider in order to decide whether should we do a prostatic biopsy or not, we consider the PSA velocity. That means the rate of rise of the PSA over time. The faster the increase, for example, if today patient comes in and has an elevated PSA or normal PSA, and then comes to you, let's say after a month or 3 months, and the PSA has increased, and maybe you can suspect maybe it's an infection or something else, you give it time, and then still after let's say 6 months, you repeat and the patient's PSA has increased. That means its rate is increasing at a very fast rate. You may suspect prostate cancer. In this case, you may do a digital rectal exam and also send the patient for biopsy. There's also what we call PSA density. This is you get the amount of PSA per volume of the prostate. So the amount of PSA and then the prostatic, using your ultrasound scan, you can know the prostatic volume. So if the prostatic density is very high, usually we consider 0.75 above it, then there is a high risk of patient having prostate cancer. That means you need to send them to do a prostatic biopsy for confirmation. Also, PSA plays the same role. So all these is, like we said, it is to guide you. The prostate, you use the PSA to guide you whether you need to send the patient for prostatic biopsy or not. So further, like I said, diagnosis is confirmed by biopsy, and that can be either ultrasound guided biopsy or index guided biopsy. So the imaging of the prostate. So when you're confirming about prostate cancer, you want to use, of course, your clinical acumen. You do the exam, but also you have other things that can help you, and imaging is one of those things. We commonly use ultrasound scan. The standard ultrasound scan that is recommended for investigation of prostate cancer is the transrectal ultrasound scan. You should note that I've not talked about the abdominal ultrasound scan, although commonly this is what we use. The abdominal ultrasound scan may not give you, one, it's user dependent. Two, it's not as, it may not give you all that you want to know about the prostate. So the transrectal ultrasound scan is the one which is commonly recommended, or what we call a TRUS. Sometimes they call it a prostate sonogram. So it's what we usually use. It is used to look at the prostate and assess its tissues. So it will tell you if there are any calcifications, if there are any nodules. The nodules that you're not able to palpate, the ultrasound, the endorectal ultrasound scan may be able to identify them. And other imaging modalities may be the pelvic ultrasound, the pelvic MRI may also help you to note, especially early prostate cancer. The pelvic CT may not see it early, but it may help you in staging of prostate cancer, and we shall see more about that. For late or when you're suspecting metastasis, you can use a bone scan, and also sometimes, especially in our low resource settings, I'm working up country, so sometimes if you don't have access to a bone scan, you may have to use a lumbosacral X-ray, depending on how a patient has come to you. So staging, how do we stage prostate cancer? Staging is a way of describing the cancer so that you know the depth or the extent of its spread. It is usually used to determine, one, the prognosis of the patient, and also to decide on how to manage the patient. So we commonly use the TNM staging, whereby T is for the tumor, N is for the nodes, and then the M is for the metastasis. In this slide, I try to show an easy pictorial view of how we stage that cancer. Okay, T0 when there is no evidence of a tumor. T1, the tumor is clinically inapparent. So you will put in your finger, you palpate, you do not feel anything. Sometimes the patient may not also have symptoms, or sometimes they may have symptoms. Okay, the T2 is when the tumor is now palpable, but it will be palpable but confined to the prostate. With T3, the tumor is beyond the prostate itself. So our next slide shows you the, especially this is for the sake of the medics, the further classification of those the T stages. With T1A being less than 5% of the prostatic tissue. So because T1 is inapparent, sometimes, you know, we do surgeries, what we call transurethral resection of the prostate, especially in BPH, when patients have issues with their prostates and the prostate has enlarged. So you suspect it's a BPH. You take the patient and you want to create a way so that the patient can be able to urinate, to pass urine easily. But when you remove off those chips, you do not throw them, you send them for histology. The purpose is that in case there is early prostate cancer, so that you can be able to identify it, and of course you can give treatment to such a patient. So for T1, if the tissue is less than 5%, such tissue is less than 5%, that is a T1. T1B is when the tissue, part of that tissue is more than 5%. In more than 5%, you find prostate cancer cells there. Then T1C, the tumor can be identified by the prostatic biopsy, what we commonly do, whether it's index guided or ultrasound guided. In our setting, we do not have, I think, MRI guided biopsies, but I think they'll be coming soon. So like I said, T2 disease is the one whereby it's palpable, but it's confined to the prostate. With T2A being less than half of the lobe, T2B more than half of one lobe, and then T2C with both lobes getting involved, but still confined to the prostate. T3, the tumor, you're able to palpate it now because it's beyond the capsule. With T3A, just extending beyond the capsule, either bilaterally or unilaterally, but with T3B, it invading into the seminal vesicles. And we looked at the anatomical location of the seminal vesicles. T4 is the tumor which is fixed or invades the other, now the surrounding structures, which we had seen before. So the N talks about involvement of the lymph nodes, with N0 when you have no positive lymph nodes. It can be seen on MRI or on a CT scan, on a pelvic CT scan. N1 talks about, tells you that there is invasion of the regional lymph nodes. Now, M talks about the distant metastasis. If you see M0, that means there is no distant metastasis. When that means you've done your imaging and there is no distant metastasis. M1, there is distant metastasis. Now, the M1 will also be subdivided into M1A, M1B, and M1C. M1A, within that, there is metastasis in the non-regional lymph nodes, not the lymph nodes now of the prostate, but the lymph nodes maybe in the pelvic region. M1B to the bones, like we talked about the sacral bones, the lumbar bones, and M1C into the distant structures, maybe the lungs, maybe the liver. That is M1C. That's what we call prostatic disease. So as we do, like we talked about the biopsies, usually when we are staging prostate cancer, we also talk about the Gleason score. This is especially for the medics to be able to understand why do we talk about a Gleason score. So the Gleason score is a kind of tumor grading also. It was initially, there were 5 gradings which were starting from 1 to 5. However, this was revised and now we have a modified Gleason score, which usually starts from 3 to 5. So 1 to 5, they were all the architecture, the structures of the tumor cells. So when they revised them, they realized that the tumor cells that were in the grade 1 and grade 2 were actually well differentiated. That means they were non-cancerous. But then the ones which from 3 to 5 are the ones which were causing more issues, and they were usually falling within the moderately differentiated or the poorly differentiated. So those are the ones which we now consider. So further, when they reviewed, now this is the International Society of Urological Pathology. When they looked at these tumors, they decided to give them grade groups, and the grade groups start from 1 to 5. So any person who has for the Gleason score, for you to get the score, you get two patterns. You get a pattern which is most abundant, and then another pattern which is secondary to it. That is also the second most abundant. So usually you have to add up these patterns and you get your score. So if, for example,
you have taken 75% of your time.
Okay. So if you have, for example, a Gleason score of let's say 3 in your pattern, and you see that the pattern is only 1, you can double it and you get a Gleason of 6. But if you have a Gleason, let's say of 3 plus 4, you can get a Gleason score. I mean, a pattern of 3 plus 4, you can get a Gleason score of 7. And so we end up having different grade groups. And so with the grade group 1 having a Gleason score of 6, grade group 2 having a Gleason score of 7, but the most abundant being a 3, which is of less differentiation. Then the grade group 3 having a Gleason score of 7, and so on and so forth. The worst Gleason score is, of course, a grade group of 5 with a Gleason score of 9 to 10. That gives you a poorer diagnosis. So categorization, I think this one I had already mentioned. We use the Gleason score, and also we classify now the risks. Okay, we classify the patients into low risk, intermediate risk, and high grade risk. And what do we use? We usually use the tumor staging, the Gleason score, and of course the PSA. A low risk patient will have a Gleason score of less than 6 or less, and a PSA of less than 10. If a patient has a PSA of between 10 to 20, excuse me. So if a patient has a Gleason score, I mean a PSA of between 10 to 20, and a Gleason score of 7, there will be intermediate risk. And high risk will be a patient with a more than T2C stage and a Gleason score of 8 plus PSA of more than 20. So the prognostic factors for PSA include the Gleason score, the tumor stage, and of course the baseline PSA. Sometimes the pathologists, good pathologists will report to you the percentage of the biopsy, of the core involvement of the biopsy. So that also gives you a prognosis. So how do we manage prostate cancer? There are different managements of prostate cancer depending on the risk. So the risk stratification usually helps us to decide on which kind of treatment we give patients. So one of the treatments, you can have lifestyle modifications. Sometimes you may decide to give deferred treatments whereby you can just watch the patient, what we call watchful waiting or active surveillance, and we shall look at their differences. But sometimes you may decide to go aggressive and you do a radical prostatectomy. That means you remove the prostate plus its seminal vesicles and other things. Sometimes you may use radiation therapy, which may include external beam radiation therapy and brachytherapy. But other times you may use medical management, where we do androgen deprivation therapy. Other therapies include thermotherapy, cryotherapy, HIFU, which is high focal therapy, high intensity focal ultrasound therapy. Or sometimes you can use laser ablation or chemotherapy, especially in metastatic disease. So I talked about the lifestyle changes. You can use diet. Encourage patients to have lots of vegetables, reduce their fat intake and especially red meat, and encourage them to take lots of vitamins. Encourage patients to exercise and also encourage them to lose weight so that they are not obese, because it's one of the risk factors. Smoking was one of the things they encouraged but it was not really found as one of the risk factors. So what do we mean by watchful waiting when we say watchful waiting? So patients who have a life expectancy of less than 10 years with low-grade risk or low-grade cancer, prostate cancer, we just watch them. The purpose is to monitor them and see if there is any risk for them or cause of disease. You don't want to start them on treatments because their life expectancy anyway is not long. Now, for patients who have life expectancy of more than 10 years, but they have low risk cancer, prostate cancer, you'll do active surveillance. The purpose is to delay primary treatment until there is histological evidence of cancer progression, because prostate cancer does not always progress. Okay. And these are the differences between active surveillance and watchful waiting. I'm not going to go through them, but I've mentioned briefly about it. You can go through the slides. The main management for prostate cancer, the cure, it is usually radical prostatectomy. It is indicated for patients who have low-risk disease, but even those with high risk, but if the disease is organ confined. It is also indicated for patients who have a life expectancy of at least 10 years or more, but also age is a factor. For patients whom you see that their age is higher, I mean lower, but they are weak, you may not do radical prostatectomy on them. But it's the gold standard of treatment, and its intention is really, it's mainly cure. It's to cure the disease. Apart from radical prostatectomy, we have hormonotherapy. And in this case, we use, we target the testosterone producing areas or the testosterone cycle. So for patients, especially in our settings, we can do surgical castration or medical castration. And this is what this slide is trying to talk about. It's indicated for stages from T1 to T3B and a selected few cases of T4 disease. When I talk about T4, I hope you understand because I had already explained. And for patients whose the Gleason score from around 6 to 10, you can still give hormonotherapy. Usually you do not have an upper limit to stop you from having. However high the PSA may be, hormonotherapy can be indicated. And there are different classes of hormonotherapy. I've indicated them in that slide. The thing I wanted to maybe highlight is that side effects of hormonotherapy. You may have a patient coming to you, they'll have a history of prostate cancer, and they will tell you that I'm on these kind of drugs, but I'm facing such side effects. So castrate therapy may give side effects such as loss of libido, they may have erectile dysfunction, they may be like what we call menopause for the men. They may have hot flashes, they may have gynecomastia, they may have decreased bone density. That's why when we put them on drugs like hormonotherapy, we also put them on calcium drugs, which can prevent osteoporosis. They may present with muscle wasting, so you can encourage them to do a lot of exercise. They may present with other complaints. But those who are on estrogen therapy may present with cardiovascular toxic effects. So you have to watch out for that. So what do we want to say as far as prevention and early detection is concerned? Because that's what we want to know as far as prostate cancer is concerned. We want to encourage our men, our fathers, our uncles to always go for regular checkups, or to the urologist or to their general doctors. You want to counsel these patients about the need to do regular screening. You want to encourage them to do PSA screening tests whenever there is a chance, especially annually for patients who are 45 and above. In case such patients come to you, you do not lose much to do a digital rectal exam. You should encourage them to have a health lifestyle choices. For example, let them have a good diet, let them do exercise and so on. And also encourage them to discuss with their doctors and also with their families. So as I conclude, I would want to leave this with you to be vigilant and live a healthy life. You should, whether a patient has been diagnosed with prostate cancer, they should never give up. This is a disease which can be conquered. Thank you very much.
Yeah, thank you very much, Dr. Josephine, for that wonderful presentation. I think, colleagues, you have been listening in very well and taking notes and noting down some of the questions that should be asked for proper classification or deep understanding of the topic about prostate cancer. We are opening the session for questions. So, Dr. Josephine, I think you get ready to be taking note of the questions that come from members so that we can, they can be able to get answers, of course, following the presentation. I will start with my own question. In your presentation, you indicated that in the epidemiology, specifically, Black men are more affected by prostate cancer compared to the white men. And I want my question to go to this particular bit. There was a study done. Of course, we all understand that the white men are black. I mean, the white men have light skin, are light skinned. Black men, of course, are darker skinned. And this study, to my best of my knowledge, was done from the Western world or the West world. So where there is there is little sunshine, and most of the people working there are indoors, so they are less exposed to the sunshine. Of course, that helps in the production of vitamin B, which is also associated with the protective element against the prostate cancer. So it is against this background that probably when you are darker skinned, let me start with the white skinned. When you are light skinned, then you'll be able to absorb the little sun. Using little sun, you'll be able to absorb enough to generate enough vitamin D to protect you. But when you're already darker skinned and you are in an enclosed environment, which is common with the whites, or even the UV light that your body is capable of absorbing to be able to generate the vitamin D. If you are black, then that will be there will be a reduced level because you already have a protective skin. So, my question is, was another study done in Africa? Because now African men, the black men in Africa, get enough sunlight, and their skins are dark. So because there is abundance of sunlight and they are always outdoors, they are able to get enough vitamin D. But the black men in the West world do not get enough vitamin D, having a darker skin that is protective. So my question is surrounds around that hypothesis. So I would want to know whether there was another study, because this study, I understand, was done in the West world. Thank you very much. There is a hand. This is Mr. Hamis Nagenda Wala. Please unmute and speak.
It's interesting the way you pronounce my name. This is Dr. Hamis Gendawala. I am not a medical doctor. I'm a doctor because I have a PhD. Thank you, Dr. Namugenyi. This is one of the most interesting presentations I've listened to. I went for a general checkup because our institution encourages us to do a thorough checkup of the whole body. And my doctor told me that there was that my prostate had increased slightly. Either it measures some centimeters. I don't know what the normal one measures, but he said either it increased by 3 or 3 centimeters. I didn't understand, but he said that most likely it is most likely because of age. So I wanted to know whether what kind of expansion can be accommodated as related to age, where you say, okay, if the expansion is within this range, then that is acceptable, or any form of expansion should be a cause for worry. But also, I don't know whether Dr. Namugenyi is willing as well to share contact maybe where she can be found if it's not in Soroti Hospital, because sometimes it's very important to see experienced people like her. Thank you very much.
Paul, you can pick some questions from the chat, or doctor can answer those as we get those from the chat. Yes, doctor.
I'll start with Paul's question. If such a study has been done. No, not yet. Okay, I haven't come across such a study. But as far as vitamin D is concerned, and you're talking about environmental factors, right? The environmental factor, as in vitamin D alone, may not be the reason as to why the Americans were found to have a higher incidence of prostate cancer. Because that means here in Uganda, in our African setting, that means we would not be finding a lot of prostate cancer the way we are finding it. The instances are actually high. There are studies that are currently ongoing. There is a study that is being done in Eurocare, and so far they did not. I don't think vitamin D is one of their studies, but they were talking about the prevalence, and the prevalence was quite high. They are doing, I think they already did 10 years. They are trying to do more years of prevalence of prostate cancer. But so far, their findings are that there is prevalence, and also they are talking about the genes. So for them, they are trying to study the genes. Why do blacks have a high incidence of prostate cancer? That's their study. So to answer your question, I don't think the reason why blacks were found to have prostate cancer is because of the locality where they are found, but it's more in the genes that we are carrying. Then to answer the question of BPH, Mr. Hamis, usually the prostate volume, we do not have limits. We do not say that this is the limit in which it's supposed to enlarge. Some people have large prostates. You see them in the normal volume of a prostate for a young man of 30 years is about 25 grams, okay? But as you grow, the prostate increases in size. Now, the rate of growth depends also from family to family. Usually, men of the same family may have large prostates, but the bigger the prostate may not necessarily indicate that you're going to get the symptoms of benign prostatic obstruction. Okay, I'm using medical terms, so you may get a bit lost. So you will not get obstructive symptoms. That means you may not get symptoms of difficulty passing urine. If you do not have symptoms of difficulty passing urine, we don't see the need to intervene. But if you have the need, if your prostate is large, and we are seeing that you're having problems urinating, there are ways of intervening. Either we can put you on medical management, or we can suggest surgical management. And the surgical management can also be either open or what we call endoscopic, whereby we just someone passes a knife and a camera through the urethra. They reach the prostate where it is, and they they cut off part of it. So for yourself, your doctor should have told you, one, the prostate, the volume of that prostate is, if it says, maybe he told you it is like from the normal, he should have told you what the normal is, and then told you how big yours is. And what we consider mainly, is it bothering you? If it's large and it's not affecting you, there is no problem. But if it's large and it's affecting your urinary habits, your micturition habits, then that's when we worry. Have I answered your question?
Yeah,
Yes.
Thank you very much, Doctor. We have a question in the chat. There is one from one from, I think this is DB. If my PSA is 4 and yet I get frequent urination, especially at night and with low pressure, what could be level of the risk? Maybe doctor, you will take note of that. And I read another one. Let me repeat. If my PSA is 4 and I get frequent urinations, especially at night and with low pressure, what could be the level of the risk? That's a question from BD. That is David Ramuirele. Then there is a question from Wilson Aureda Kenywa. Thanks a lot, Dr. Josephine. If prostate massage raises PSA, can't we have falsely high PSA value after DRE? How can I differentiate PCA from BPH before biopsy? Then question, of course, this is, Henry is appreciating. There is this one here from Patrick. To what extent can prostate engagement, I think was meaning enlargement, be reversed? And what remedies can you prescribe for a person with signs of prostate cancer? I think, doctor, will answer that. Some of them have been highlighted already. Then Alfred Odoi, what about this chemotherapy components of dispensing synthetic finasteride? Doctor, I've heard you mention about it. I think you just have to clarify about that. Then thanks for that great presentation. Is having frequent sex have anything to do with less likely to get prostate cancer? I think then is PSA of 66.3 NG stroke meals, I don't know what NG means, enough diagnosis? Okay, 100 milligram per meal. Okay, there is NG stroke ml, enough diagnosis prostate cancer in a 75-year-old, and that is from Seka Vida. Then Benon Naita, if the maximum upper age limit for prostatectomy is 75, what intervention is done for a patient of 78 years and above? Questions are becoming many. Okay, link. Kindly post the link. Those are the questions we have so far. Maybe you can respond to those ones. Time is fast running in about 5 minutes.
So I'll start with a PSA of 4. Was that the first question? Yes. Hello? Can you hear me?
Yes, I think so.
Okay, so
yes.
For us to know your PSA, we first of all want to know your age. If a 16-year-old, a 20-year-old comes with a PSA of 4 and has frequent urination, my first thinking would be a UTI. Okay. The range of PSA, it may range from 0 to 4. That is commonly what is given in most labs. But sometimes as people get older, the prostate, the PSA may be a bit elevated. For example, if I find a patient who has a PSA of 6 and is 75 years old, I don't think I will worry so much. Okay, so we consider age and we consider your symptoms. Frequency alone, any irritation on the urethra will give you frequent urination. The question is the duration, your age, and what are the other symptoms? How are you urinating? Okay, so we have obstructive, irritative symptoms, and then obstructive symptoms, which we consider. I hope I've answered your question. So the level of the risk depends on your age. If you're 20 years old, I wouldn't worry. If you're 78 years old, 75, 50, I would send you for screening. What was the next question? You're going to help me, Paul. Paul, what was the next question? What exactly is prostate enlargement, right? To what extent is prostate enlargement reversed? And what remedies can you prescribe for a person with signs of prostate cancer? Now, like I was saying, for one to be treated for prostate cancer, one, you need to be confirmed. You should have had a prostatic biopsy that confirms that this is prostate cancer. Secondly, if you have prostate cancer, which stage are you? We need to stage you and then to know now that, okay, this patient is this risk stratification. Is he low risk? Is he intermediate? Is he high risk? And we also need to, if it's prostate cancer and it has been confirmed, is there metastasis? The way I treat a metastatic disease is not the way I'll treat organ-confined disease. So that is the difference. Now, for prostate enlargement, again, we do confirm prostate enlargement. Enlargement alone cannot be just treated. So depending on when you come to us and you have, because both prostate enlargement and prostate cancer may present with the same symptoms, but we need to screen you and confirm that you do not have prostate cancer. However, if you have prostate enlargement and your PSA is a bit elevated, we can send you for a prostatic biopsy. The biopsy may come out and tell us there is no prostate cancer, but there is hyperplasia, which means the cells have increased in size. So that means we are going to treat you for prostatic enlargement, and there are treatments for that. There are alpha blockers, okay, and there are 5-alpha reductase drugs that we use for management of prostatic enlargement. That is if we do use medical management, but we can also use surgical management. Okay. What was the next? Have I answered that question?
Yes.
What about these chemotherapy components of dispensing synthetic finasteride? So synthetic finasteride is usually used in the treatment of BPH, not necessarily for treatment of prostate cancer. There are cases when we give it, but no, it is not a routine. Okay, so that is a drug for BPH. It is not for prostate cancer. Is there any other question?
Yes, there is this one. Should old men be encouraged to have frequent sex in order to prevent the prostate cancer? That one is an interesting one.
In the myths that I highlighted, one of the things that were believed is that frequent ejaculation predisposes one to getting or to be at risk of prostate cancer, and we said that is a myth. Now, there was no correlation that was found in studies between the rate of ejaculation and prostate cancer. So having the more frequent sex or the more ejaculation you have do not protect you from having prostate cancer. Is PSA of 66.3 nanograms? Is that it? Nanograms per mil enough diagnosis for prostate cancer? Like I said, the confirmatory test for prostate cancer is a prostatic biopsy. In this case, in a 75-year-old.
Yes.
Pardon?
It's okay, Doctor, proceed.
In for a 70-year-old, that's 66.3 nanograms of a male. In a 70-year-old, I would expect his prostate cancer, I mean PSA, to be about 6. So if it goes beyond 6 and goes to 10 and above, there is a high risk of finding him with prostate cancer. But I cannot say that he has prostate cancer until I've done a digital rectal exam and a repeat PSA. But also with those two, I sent him to do a prostatic biopsy. The biopsy is the one which will, because the biopsy takes part of that prostate, they look at the cells and they will tell you whether prostate cancer is there or not. And they will tell you which Gleason score of that prostate cancer. Is there any other question, Paul, that I've not answered?
Doctor, you have, and I think, Paul, we shall need to be winding up, and maybe we can have Doctor in another session, maybe basically a Q&A that people can ask. And I want to take this opportunity to support Paul, and thank you, Doctor, for sparing and giving us this time. I know all the challenges you've gone through, but you still had to make this presentation, and we don't take that for granted. Over to you, Paul. Do you want to proceed? Okay. If not, I want to say, on behalf of our board chair, Professor Peter Waiswa,
To have they already home having some time with their family or families. Sorry?
Okay, we're just winding up and we're just proposing a Q&A for Doctor next time.
Yes, you're saying what have you just said?
Oh, we shall have a Q&A session. We shall prepare with Doctor and have a question and answer session for people to ask more questions. But we have
exactly, because it was a wonderful session and more question is actually just coming in, they're just flowing in. And exactly as you said, we should have another session for question and answers so that people can use. Otherwise, we want to thank Doctor very much for that wonderful presentation, which is so interesting, and you can see it from the questions coming up. They're actually endless. But we also thank the members who have been able to stay on the call till this late. We appreciate the fact that you have been able to spare some time for this session. I want to ask that next time also get that, because the awareness bit, we need to have it. So next time when we are having questions and answers, we should know how we give awareness to, we have strategies to give awareness to the community, awareness to the health workers who are supposedly to be identifying the cancers early before they actually become a problem to us, because they already a leading cause of premature death not only in Uganda but also the entire Africa. But we also know that there are 20 to 30% of cancers actually preventable. So we know we can do a lot to prevent the cancers. I think we are coming to the end of the session, and I want to hand over to Benja to give us the closing remarks. Thank you very much. My name again is Charles Kerapo, a clinical officer. Thank you.
Thank you so much, Paul, and thank you for being very active. Paul is one of the very active members of SOGA Referral, and he won an award last year for being the most active member of SOGA Referral. Thank you, Paul, and Dr. Josephine. I'm really humble that whenever we are getting to you, you're always giving us this time, and probably we shall schedule and have a Q&A session for people to ask all questions that they may want. And I will even run a link for people to bring in questions for the session. So on behalf of our board chair, that's Professor Peter Waiswa, I give the certificate to you thank you for your remarkable presentation that you have given us today, the 11th of October. And we ask that you take it and you can put it in your office, in your sitting room, and we are proud of you. And then to Paulo, really, this is really good. Thank you for being a good moderator and for making sure the session is very active and participants are staying on call. We have had a maximum number of 140 participants. That's very good. Thank you so much. And I wish you a good weekend. Over to you, Doctor, if you have any last word for the participants.
I'll just say thank you very much for giving me the opportunity to have with you this lecture. Again, I'm sorry I came in late because of the issues that were beyond me. So yeah, I would look forward to that session next time. Thank you very much.